Good morning. So I think she gave you all the vital information to launch us here, but real quickly it would be helpful for me to know a little bit about the audience. Some of you have introduced yourself and the roles you play in the community. How many physicians do we have? Okay, and nurse practitioners or nurses? And then we have speech pathologists. Any other speech pathologists? And medical interpreters? And anybody else? Social workers, school? Educator. Okay, great. Thank you. Thank you for joining us this morning, and we'll try and make this useful and informative. So I apologize in advance. My talk is slide heavy, and some of them are going to be probably more useful as reference later. And I also want to encourage dialogue and questions, and so please stop me along the way or redirect me, and we'll try and get through as much of this material as possible. We will be talking about the epidemiology of co-occurring disorders. I will introduce the way I think about prescribing medications when I see a child or family who's struggling with either issues related to autism or psychiatric comorbidities, so some of the guidelines that drive my decision making. And then we will also go through the evidence base for interventions along those lines. I want to start by sharing a little bit of my experience and familiarity with the Vietnamese community. I had an opportunity last year to go to Vietnam with several other clinicians from the Seattle Children's Autism Center, and involved myself, our center director, Rafe Bernier, and Jim Mancini. We were in Hanoi and based at the Vinh Mec Medical Center, and we took a week to get a sense of how folks there were evaluating and supporting children and families with autism. It was a mix of didactics and meeting with researchers, and also trying to provide some basic instruction around diagnostic interventions and then also treatment. It was a great opportunity to exchange information and see how what I do on a day-to-day basis literally and figuratively translated into a different culture. And in some ways it kind of brings me full circle. My public health degree before medical school was in cross-cultural psychiatry and mental health epidemiology, so I appreciate this opportunity to revive that part of my brain and bring this back to relevance. So what did I take away from it? It was great to see the enthusiastic community of providers and parents there trying to figure out how to support children with autism. Very different, but also in some ways very similar barriers that we face here. Some of the takeaways were, again, not terribly different than the challenges we face here. There's just simply not enough access to educational support, psychosocial therapies, and access to medical specialties. There was also, I think, a bit more of a focus on some of the biological therapies that are experimental. That was a bit surprising to us, and so we had to navigate that diplomatically. I have had parents come to me wondering about going back not just to Vietnam, but to other home countries to explore stem cell therapy. And there are opportunities to do that in other countries that are ahead of the research. And so, again, it was an opportunity to kind of see a different approach to that and think about how to guide the families here that I see at the Autism Center who are wondering about that as an option for their child. So before I launch into the treatment of challenging behaviors and comorbidities, I just want to kind of orient you to what I do as a psychiatrist working in the field of autism. I would say this is something that's gained some definition over my career even. When I was in training, psychiatry was kind of peripherally involved in most cases in managing autism. And over the last 15 years or so, I would say the field in general has defined its role in a couple different ways. More commonly now, psychiatry is involved in assessments for autism, and that's typically a clinical interview as opposed to the application of structured psychological or behavioral assessments like the ADOS. And so I participate in autism evaluations as part of my role at the Autism Center. In general, we're always working as part of a multidisciplinary team. We're trying to apply our strategies and knowledge base with the assistance and support of other providers. That's absolutely crucial. A big part of my job is around coaching and advocacy for the appropriate psychosocial treatments and behavioral therapies so that, quite frankly, the medications I prescribe have a chance. They are good, they're not great, and without the other supports, we know that there's going to be limited benefit. So with regards to psychotropic medication use in children with autism, there are some basic trends just to be aware of, and this is a good opportunity to remind myself that I work in a specialized environment, and so I can develop a skewed sense of what percentage of children who have autism have major behavioral problems, have psychiatric comorbidities, require medications. It's not insignificant, but it's not all of them. For children, it's about half of children end up being prescribed psychotropic medications at one point or another. In terms of kind of trends we see now that we've got about a decade of I guess, more commonly or more common prescribing, is that unfortunately there tends to be more a layering of medications than alternating. And so as medications are started and that becomes part of the treatment approach, we have an important job as specialists to try and limit their use, quite frankly, as much as provide access to their use. I think that's a kind of a turn my career has taken that I didn't anticipate, more so than giving diagnosis and starting medications. It's about winnowing down diagnoses and limiting medications to where we know they can be effective. Once medications are started, I certainly have a handful of families where we've done our best to try and bring certain behaviors under control and get to a point of agreement where we really determine that psychosocial and behavioral treatments are the key. But I would say in general, once there is, once you head down that road, there's a tendency to really want to keep trying. And another role that I have is saying, hey, we've really given it our best shot, and I think, we need to focus our energy elsewhere. So in terms of how I start to communicate risks, benefits, expectations to parents, I guess some of that advice translates into my advice for you. Children with autism, the language is being debated, but certainly are considered, I think, neuroatypical. Thank you. And so it makes sense that we might not have the same experience when we prescribe medications, both in terms of expected response as well as side effects. It's also the case that when you have a brain that is developing atypically and a child who's struggling, they are more likely to have more than a singular challenge. Not always, but comorbidities, co-occurring disorders is more the rule probably than the exception. And in terms of the exploration of the origin of any problem or symptom, it is really about interpretation and detective work. Common disorders present uncommonly, and so it's a lot about understanding the context of behavior, the patterns of behavior, trying to infer whether there might be a emotional valence or corollary that could lead us down a road of maybe an affective disturbance as opposed to simply a behavioral disturbance. And then finally, there's the challenge of kind of, I work in a world of overlapping Venn diagrams, and so there's a lot of overlap in symptoms and diagnoses, and even recently I've started trying to draw 3D Venn diagrams because 2 dimensions just wasn't cutting it. in my brain and for parents to illustrate that the overlap of anxiety and intellectual disability and autism, there's just so many intersections, and each influences the expression, interpretation, and support of the others. So how common are common co-occurrences? Pretty common. So, intellectual disability has gotten a lot of attention recently. I think it's, related to a focus on genetics and recognition that there's a lot of vulnerabilities there that are shared between intellectual impairment and autism independently. It's also the case that the children with intellectual disability have higher degrees of impairment, and sometimes that's the source of their challenges more so than autism. That could be said for psychiatric issues as well. So I think it's incredibly important that psychiatry has found something to contribute to this field, because for a long time I think trying to understand whether the expressions of behaviors had to do with neurologic deficits akin to ADHD or affective disturbances akin to anxiety. I think it was rather by chance that this was identified and children were supported along these lines. Most commonly, I see ADHD concerns, more generally executive functioning concerns, of which ADHD symptoms are a subset, and disruptive behaviors. Certainly, it's important to be aware of the increased risks of psychotic disorders, but not something that is nearly as common as the affective disorders. I'll say a little bit more about that later, because the report of hallucinations is a scary thing for parents. It's a common reason I get phone calls from some of you. By the way, have I spoken with many of you at the Partnership Access Line? None of you. Wow. One of you. Great. Well, I'll provide some more information on that, because I want to encourage you to call and we can talk through some of these situations. But at any rate, that's a common reason I get calls from primary care providers when parents or children report hallucinations. That's something that can be alarming and scary for families, and so helping you talk about that with your families and with the children is important. But again, hallucinations, the frequency of hallucinations is not a good indicator of the frequency of psychotic disorders. I'll just put that out there. So again, I think I've mentioned most of this. The rationale for identifying these issues is that in many situations they are the cause of more disability. An example here would be a high-functioning child, at least in terms of cognitive abilities and language abilities. I think that's a tricky language to identify who's high-functioning and low-functioning, but that's a conversation for another day. But at any rate, children who are traditionally considered high-functioning and more psychologically aware tend to have more affective disturbances along the lines of depression and anxiety. And oftentimes, those are the issues that cause the most distress, the most impairment, and certainly are the reasons that children end up in my office. So how do I approach the decision-making process when I have a parent or a child who's coming asking for medication? I try and sort through whether the expectation is that we will be treating autism versus whether we will be trying to improve a particular behavior versus whether we're targeting a true co-occurring disorder. I think this distinction is important, and I'll make the point in different ways as we talk through the medication strategies. But with regards to the core symptoms of autism, there are no medication treatments that target those symptoms specifically. The message has gotten a little more complicated recently, and certainly in the work I do, I can see improvement of some core symptoms, but there are no medications that you can tell a parent are going to treat autism. Most commonly, I would say I'm doing symptom-driven treatment. I don't often have the luxury of diagnostic clarity. And quite frankly, it's not always helpful. You're trying to figure out what's helpful for a child. whether it's medication or other treatments. And so it's often the case that the focus is on a symptom or behavior, and we kind of plow ahead with a differential diagnosis that we're slowly working through over time. The key to clarity in terms of diagnosis and what I do is longitudinal work with kids and families and see how things play out over time. And that certainly is I think, more reliable than trying to come to a specific diagnostic conclusion early on in treatment. Certainly there are situations where it is very clear and you can provide information and support around that, but I'd say more commonly we're doing symptom-driven treatment. Certainly if there are identified comorbidities that stand out or stand alone, then support is provided around the prognosis and treatment of that disorder in the context of autism, and may take different forms depending on the developmental level of the child. Does this distinction make sense to folks? Any questions about this? You know, a lot of parents are focused on understandably understanding why their child is struggling, and so they want a diagnosis. And I think you can sometimes give them answers, you can give them answers, but also shift away from that word because that has a finality to it. And you know, I'd rather provide a context or an explanation for a behavior than add another label. And I think you know, these children with autism are at risk of accumulating diagnoses, psychiatric and otherwise, and so reframing challenges as a consequence of autism-related issues, I think, can keep the focus on the right thing. Yes?
I have a quick question. So as a PCP, I get a lot of desire from schools to have a diagnosis for IEPs and accommodations, and I feel like, from my standpoint, I don't feel comfortable doing any diagnoses for kids with a lot of severe delays versus like a teenager who can speak, you know, for like a GAD or PHQ or something else.
Right.
So I agree with your approach, but then
it doesn't hold quite the weight sometimes, you're right, in terms of schools stepping up and doing what they're supposed to. Also, we know with other systems, DDA wants a little bit more than irritability and aggression, right?
Yeah, or like rule out something or rule out, you know.
Yeah.
It's
even,
like,
right, even rule outs and provisionals aren't going to cut it. So you're right, we are navigating a system that's asking us for certainty, and at times when we don't have it, and it's not necessarily in the best interest of the child. I think you have to approach that on a case-by-case basis. It's interesting that that's your experience, that schools want a medical diagnosis. I guess that makes sense to me. I'm kind of thinking about the general trend that they don't want to make those diagnoses, but they want the diagnosis. That distinction's important. Yeah. So maybe yes.
I think that's where the challenge lies, when it's not a diagnosis that I personally would feel comfortable making, but then access can be challenging, especially for non-English speaking patients who aren't very good at coordinating care. So I can advocate on their behalf, but if it's sort of like that in-between gap where the school nurses are calling on speed dial because you have a young child who's having severely aggressive behavior and who's injuring staff, and they're like, we need to do something, but then it's also, you don't want to label somebody with something that may not be accurate, that could be unfairly stuck with them down the road, and may like impede accurate care. But at the same time, when there's like a long delay and gap in terms of accessing things, you're still there with the family and you still want to do something to help.
Absolutely. So that's when you can call me at the Partnership Access line and I'll give you a diagnosis.
I have people on speed dial.
Several to choose from. No, that's hard, and I think, you know, I'm more familiar with the diagnoses that are sufficient for services in the mental health system than the education system, so I'm treading in unfamiliar waters here, but if there is a more general diagnosis or less stigmatizing diagnoses, I would suggest you go with that. So adjustment disorders are a great way to work around that issue in the mental health system. It provides access to care, and it identifies the circumstances, it gives enough to kind of describe what's going on, and then you can kind of, again, work through diagnostic possibilities while the child is in care. So it's one of the many flaws where our system is kind of turned on its head. But yeah, I understand your predicament. But that's a great reason to call and talk to us about the situation, myself and my colleagues, and we can help you decide, could you get a couple more key pieces of information that might give you enough certainty to give a diagnosis, or is there a better, more general alternative that could allow for things to unfold? Yes?
So for the question of autism, if you're referring for an evaluation, you're going to wait 18 months. In the interim, you could diagnose like an F89, which is like neurodevelopmental disorder unspecified, as a stopgap.
Yes, thank you. And there are, there are parallels in other areas as well. So I think becoming familiar with your most comfortable diagnoses, where it marries with what's sufficient to get services, is probably what I would recommend in each of these areas. Yes?
Hi. So I hear what you're saying. The question I'm having, though, is like my biller, for instance, is trying to train me to use no unspecified codes because she says we won't get reimbursed.
I'm trying to get you to use what?
To not use unspecified codes because we won't get reimbursed. Like, for instance, my biller is trying to train me that you have to bill in order to justify your time. I spend a lot of time with patients because they're super complicated. And she's trying to explain to me, and I'm very new at this. As a provider. So I would love it if there were some resources that you could pass along, maybe later, to help us see more of the codes that you're finding acceptable.
I will be happy to think about how I can be helpful. That is a very, it really depends on who's asking. So school systems have their own needs. Each insurance company, if your insurance company is starting to not allow unspecified diagnoses, and for all so unspecified anxiety disorder, not just an unspecified diagnosis. So depression, unspecified depressive disorder. So you're still identifying generally the domain, right? Those are the ones you're finding are being denied. Again, it's going back to the insurance company, learning which ones they will reimburse, and then seeing how you can work with that or advocate for changes. And that's a big part of our job in many ways, is saying this isn't appropriate, this is potentially problematic or harmful to the child. So, it's going to be a different strategy and different solution depending on who's asking and why. If they start striking those from the options, it's going to be tricky. There's going to be a lot more false certainty, and kids are going to have a lot more labels to shed over time, or diagnoses to shed. So I have a lot of questions. I don't have all the answers. So what do I think about when trying to decide whether medications are appropriate? It's certainly, as in many of the clinical context, it's about severity, it's about frequency, it's about impact. The presence of a appropriate target behavior or symptom does not necessarily mean we're going to chase it with the medication. There's not a one-to-one correlation. Certainly the potential impacts of the behavior need to be considered. If there's the potential for harm to the child or others, or if there's the potential that a child is going to lose a placement or have to leave their home, that adds a level of urgency. The question of what level of behavioral support is available, that can kind of cut both ways. Certainly there are circumstances where medication is indicated to support behavioral therapies. There are situations where we want to hold off on medications for specific target symptoms if there is access to behavioral therapies that we know to be potentially helpful. But sometimes we are left with the reality that certain behavioral support isn't available, and you have a family that's struggling, you have a child that has a behavior that's severely impacting the family's quality of life, severely impacting the ability of other children in their class to learn. And so you have to kind of do the calculation differently each time, I think. There are circumstances where I might be asked to initiate a medication to support a time-limited intervention, and so we might take that opportunity. So For example, working closely with our behavioral team, they've got 10 weeks to try and bring some really pretty severe behaviors under control. I may not have the luxury of doing my full process up front, but I have the confidence that they're working with experienced providers who are saying, hey, let's give this a shot because it's going to really help me work with this family in the next 10 weeks and allow this child to even come to the clinic and stay in the clinic. So, we might in that circumstance, again, provide the medication support so that the behavioral treatments have better chance of success. And then certainly if there are if there's enough impairment or symptoms, or it's clear there's a co-occurring disorder separate from autism, that makes it a little bit more clear that medication sometimes can be the key. But again, case by case, first-line treatment for anxiety, first-line treatment for depression, at least mild and moderate for children and even into young teenagers, is therapy. Ideally, I'd like to be able to tell parents to find someone who can do developmentally appropriate CBT. I use that phrase a lot, and it makes a lot of sense to me. The reality is it's hard to find folks who are doing that, but more and more they're out there. We maintain a good resource base at the Autism Center, and there's a new referral service that I will mention a little bit later that also can help find. Holy smokes, 10 minutes. I'm going to start talking really fast. So, all right, slide heavy. I was warned. All right, so how does this affect decision-making? It sets expectations around responses, side effects, that kind of thing. Response rates are much lower in children with autism in general, and side effects are much more common. If I'm doing symptomatic-driven treatment, it's going to be a little bit different than if I have a child without autism who I comfortably diagnose ADHD, and I just kind of find something that's effective, and we work to optimize that and kind of hold the course more or less. Certainly not the case in autism. It's a bit like a game of whack-a-mole, especially when you're working with lack of diagnostic certainty. And I would say there's nothing akin to kind of set it and forget it in medication management in children with autism. Regular follow-up, regular evaluation of side effects, incremental response each time, evaluation of incremental benefit each time you adjust a medication. It's a very active process, and this is a conversation I have with my leadership sometimes at the Autism Center because there's interest in getting new kids in the door, but it's hard to sometimes, as a provider and for families, to say, all right, we've got this figured out, and send them back to you guys. That doesn't feel good to a lot of folks. So repetitive behaviors, I'm going to really move quickly here, so I apologize. Still pressure me, but all right. So criteria B, these symptoms, at least when we're considering medications, the repetitive behaviors more so than the cognitive rigidity, they tend to wax and wane on their own. So sometimes you kind of feel like you're chasing something, you got it under control for a little bit, and then you're off track again. And sometimes the behaviors are pretty innocuous. And so, again, these are considerations about whether you introduce medications to the equation. Certainly if the behaviors involve self-harm or risk of harm to others, or unsafe behaviors in other ways, you need to be a little bit more aggressive in treatment. I don't think your slide sets are in color, correct? So very important here that, if you're looking back at this later, you don't look at this slide and go, Dr. Kamenisch said all of these things work for repetitive behaviors. I've color-coded for your convenience, not as fancy as our first speaker. But risperidone and aripiprazole have FDA approval for irritability in autism, not repetitive behaviors. But some of the secondary outcomes showed that some repetitive behaviors can improve, and so we sometimes go down that road if there's a pattern, if there's indication of significant cognitive or behavioral rigidity that might respond to antipsychotics. SSRIs, there was a big Cochrane study that clearly kind of, conclusively ended the debate about whether specifically for repetitive behaviors you would start SSRIs, and the answer was no. And they went back and looked at all the studies that had been done. They found some studies that had not been published, and they aggregated that data and found that there really wasn't a significant. So in yellow here, it's indicating that it's may be helpful. It is not FDA approved. The only two medications approved for treatment of children with autism are Abilify and Risperidone. And again, those are approved for irritability in autism, not what we're talking about here specifically, which is repetitive behaviors, although there can be a relationship. I'm not going to belabor, I think, all of this information. In fact, I think I've covered most of it. It is hard to predict who's going to respond, really, with regards to most of what I'm going after here. Regardless of the medication or the target symptom, there's not enough information or research about predictive phenotypes. And so, which children will respond to atypical antipsychotics for repetitive behaviors or behavioral rigidity, it is kind of a try and see circumstance. So it's really about the severity of the behaviors, the impact on this child, balanced against the potential side effects of the medications, which are significant. And I've made this point that there is, not good predictive information about who's going to respond. High rates of adverse events, like all medications, when used in the context of autism. And, certainly there's a distinction to be made between children who have repetitive behaviors for whom autism is the primary etiology versus someone who has co-occurring OCD. In that case, there would be a stronger argument for trying SSRIs. In terms of the A criteria, social communication, there are no medications that are approved. Oxytocin is being looked at closely. Seattle Children's has participated in a few studies, so you may see some of your children who have participated in that study. I certainly see some for follow-up at the Autism Center. Some felt it was helpful. Some parents felt it was helpful. Some did not. I've had a few ask me to continue it, and so it's a little bit more common than several years ago, but certainly not something that I think is being initiated often by psychiatrists, and I presume less often by PCPs. Irritability, probably the most common reason I see kids, although sleep is up there as well. And again, this is where there are some medications that have FDA approval. They don't come, it's not an easy decision usually. They come at a cost. Side effects are significant. How many folks in here prescribe atypical antipsychotics for their children with autism? Are we in kind of not something that's terribly relevant to your practice? Okay, that's helpful for me. That'd be a good reason to call us then, and that's a frequent reason we get a call. Hey, we've tried stimulants, we've tried alpha agonists, and now we're kind of thinking about an atypical. Does this make sense? Can I do that, or should I send them to see you? And we have the most experience with risperidone and aripiprazole that kind of led to their approval and why we go to them, but certainly there are others that you will probably see children on when they come out of the inpatient unit or sent back to you for ongoing medication management from a psychiatrist. So if you have questions or concerns about something one of your patients is on, give us a call. Yes?
The ketapine and lamotrigine at the bottom, why were they in red? I missed that.
So my color coding here, thank you for making me clarify. Green means there's FDA approval. Yellow means there's not approval, but they can sometimes be effective. And then red is that they've either been studied that they've been studied and there were negative studies. But do I have children on quetiapine for whom irritability has gotten better? Yes. Do I have children on lamotrigine? Yes. So these are the guidelines. This is, merging kind of experience and evidence base, just some of the information I take into account when trying to decide which road to go down, which medication to try, and certainly there are differences in side effects between even the different antipsychotics, and so that comes into play. In general, with the antipsychotics, I'll just kind of merge the two slides, this one and the one on Abilify in the interest of time. We're not talking about typical antipsychotic doses. We're talking about lower doses that lowers the side effect burden, but also typically is effective if it's going to be effective. Getting into the higher dose range is not necessarily going to make a difference. I will say with Abilify, it's got a unique mechanism, and so sometimes you will see higher dose ranges there, a higher dose there than you will see with other antipsychotics. Don't be alarmed by that. What the provider is trying to do, prescriber is trying to do, is capitalize on the dopamine activity, and that can take higher doses. Unfortunately, there was a period of time when we were hopeful that Abilify would be better generally in terms of metabolic side effects than risperidone, which is a major limiting factor in its use. The reality is in children that doesn't bear out. For hyperactivity, this is probably where we have the most tools, but again, predicting the response is tricky. In some ways, it feels like we've got the most tools. In other ways, it feels like we're just kind of trying one of each. But the reality is irritability can be treated in many different ways. It's hard to know for a particular child whether sometimes anxiety is at its core, or maybe it's hardwired executive functioning deficits, or perhaps it's frustration tolerance and a lack of functional communication. And so depending on what theory you have behind the behavioral issues, whether it's hyperactivity or irritability, you might choose one or the other. Risperidone and aripiprazole have been shown to improve hyperactivity, and methylphenidate can be helpful. It's a little less consistently and has a high side effect burden. For some, atomoxetine alpha agonists can be helpful. I don't prescribe and rarely see naltrexone, so that's up there for completeness sake. I wouldn't spend too much time or energy on it. Certainly amphetamines are not uncommon, but usually as a second line after methylphenidates have been tried. Just usually they are a little bit trickier in terms of side effects. Amantadine, a few children have had benefit from that where everything else has failed. Give us a call. We'll try and help you decide which makes the most sense. Yes?
Like 4 milligrams of Abilify, but then it takes like 2 months to see you guys. And I'm like, and he's kind of aggressive, acting out in schools.
It's a function of age, size, and severity of symptoms. I would say, how old is the child?
6, or not, 8.
8. It's not an easy answer for that. I think it's evaluating incremental benefit and weighing it against side effects. And so I might think of 5 to 10 milligrams as a maximum in an 8-year-old. But again, it depends on really what you're targeting, how severe the behaviors are, how well he's targeting it. But
I think he was on 4. I increased it to 5, and then his dad was complaining of side effects. So I'm like, well, what to do? Just wait for you guys.
I'm sorry?
Is there like a phone number I can call you guys?
There is. I will give you that. We'll give you materials with that phone number, and we can talk you through it. All right. I'm going to spend a minute on the alpha agonists just because I think they're probably more commonly something you use and can be effective for a number of treatment targets. They can improve ADHD-type symptoms, impulsivity, hyperactivity. We often end up starting here if we're targeting irritability primarily because of the favorable side effect profile versus the atypical antipsychotics. There is an element of wait and see with them. They take a while to do their thing. Alpha agonists have a very narrow therapeutic their dose range. And so, it's probably the case, I would say, more so than any medication, that we want to get kids up to the maximum recommended dose for age, give it a few weeks, and then evaluate things. I think a lot of kids are started on them and don't get sufficient dosing, and then they're kind of deemed ineffective, or another medication is added without having the benefit of time and therapeutic dosing. They can also be helpful when you're targeting sleep as well, and as we all know, there's a huge correlation between irritability, executive functioning deficits, and sleep. So this is where I kind of feel like I'm sometimes selling snake oil. I've got a medicine that's going to help with sleep and irritability and executive functioning and maybe even anxiety. And it feels a little disingenuous at times, but that's the experience and the reality of the situation. I think we've covered most of these points. With all the comorbidities, they can mimic and exacerbate autism symptoms. They can also increase disability, and it's important when you're struggling to make decisions, or I guess when I'm struggling to decide whether medication is effective, make sure, again, that the non-medication strategies are being used. If there's opportunities to advocate for that and reinforce that, take that time and energy, because it's going to be well worth it in the long run. In general, long-acting preparations are more effective and better tolerated. As I mentioned, anxiety is very common. This is an area where there's a lot of time and energy spent trying to tease out our repetitive behaviors, a function of anxiety or a function of autism. And similarly with socially avoidant behaviors, that can be a function of anxiety versus primarily due to autism. So, this is common territory for me. I think also lesser, not as obvious, cognitive and behavioral rigidity is often a symptom of anxiety. It's not really captured very well in any of the anxiety diagnostic criteria, and I think autism is kind of similar to younger children with anxiety in that you kind of got, again, do a lot of interpreting of behavior and try and understand whether there's an emotional correlate or valence that's akin to anxiety. And again, if it's available, first-line treatment for mild to moderate anxiety and autism is cognitive behavioral therapy, deployed, used by someone who is familiar working with children with autism. And in general, it's reasonable to consider the full range of anxiety medications. Depression in autism is fairly common, typically in higher functioning kids. That kind of makes sense. Those who are aware of the unique challenges they face navigating the world due to autism are more likely to have a negative psychological response and feel the impacts of how they're treated differently or perceived to be treated differently. And so, screening for this in older children who are relatively or high functioning is important. There are no standardized tools, so it's again, interpretive. It's hearing about challenges. It's evaluating changes in social function, neurovegetative symptoms. And depending on the developmental level of the child, you might, be relying more on changes in behavior than reported affective changes. Suicide and autism, I think I'm going to conflate these two slides here just to say that these are both more common in autism than children without autism, trickier to identify. And in both cases of suicide and psychosis, autism is an independent risk factor. And so keeping these things in mind is important when you have identified psychological challenges or emotional distress in a child who has autism, and take into account the challenges that are unique due to communication deficits, and it is, makes sense to try and support children in a way that's going to mitigate some of the stress of this. So supporting social functioning, preferred activities where they can have connections with peers that can buffer against this, and also provide an avenue of support is all very important. Psychosis, similarly an independent risk factor. I would say the debate here is a little, or the conversation is a little bit different and perhaps a little bit more interesting depending on your perspective. Historically, autism and schizophrenia were merged, and they have separated diagnostically through the years. And now with genetic studies, we're seeing overlap in risk genes. And so, one of the cultural aspects of autism in Vietnam that I learned about was the fear that autism meant your child was going to have schizophrenia when they were older. And that prevented a lot of parents from seeking help because it was a way of kind of acknowledging this was the reality and they didn't want to acknowledge that. So in some ways, we want to be reassuring that autism is not childhood schizophrenia, but as clinicians, as scientists, we understand that it's a little bit more complicated and that there is some overlap. And certainly some of the trickier cases I see are children who are diagnosed with autism early that start to have psychotic prodromes, and vice versa, children who are diagnosed with psychosis, and then you go back and look at school records and get better history, and you learn, well, maybe there was autism here. So I think we can all, again, reassure families that there's not a one-to-one correlation, but be aware that psychosis is more common in children with autism than without. And again, I'll just make the point about hallucinations that it's, psychosis is more than just hallucinations, and all hallucinations are not psychotic. And so if that's uncomfortable territory for you, or you have a patient for whom this is an issue, please call us and we'll talk you through it. I'm on my last slide. I probably have 20 seconds. So, when should you involve us? When you want to, quite frankly. So it can be for a range of reasons. Either you've run out of ideas or treatments. If you want help deciding whether medications are appropriate, if you want help deciding which medication, if you want help trying to, if it's important to distinguish, is there a co-occurring mood disorder here, or is this just part of autism? That's probably something that's going to be better answered through a actual consultation than just talking on the phone. And certainly anytime you are, approaching the limits of your comfort zone and want guidance. And finally, again, back to kind of where we started, an important aspect of my job, again, is deciding when to use medications, but it's also probably more important holding the line when medications are not appropriate and expectations are not realistic. And so if you have parents who are very focused on medications as a solution for whatever reason, we can help steer that in a different direction. Partnership access line. Again, who has not heard of this? So people who have not heard of this. Okay, so a good number of you. So this is for primary, and I know I have a mixed audience here of different professions, but this is a resource for primary care physicians, or primary care providers, ARMPs, family doctors, pediatricians, and you can call us between 8 and 5. It's a state-funded program. It's been around for about 10 years now. We have psychiatrists standing by waiting for your calls, literally. It's at your convenience. You can schedule a call if you prefer, but we've learned that this model is much more user-friendly if you call when you have a minute. And we've got, I think, over a 90% direct connect rate. We also have social workers who can help with referral questions or research issues. There's a couple new pieces to the PAL program that you may hear about shortly. They're in various stages of rollout. There is a baby PAL, which is for peripartum mothers who are depressed, and primary care providers would like help evaluating and accessing care for the mothers. And then there is a mental health referral service, which is eventually going to be essentially a stable of mental health workers and social workers who will take calls from primary care providers and even directly from parents trying to navigate the system and get access to psychosocial treatments, ABA therapy, physical therapy. And this is not autism specific. This is mental health. And we have a mental health guide that we've put together that has lots of hopefully useful information, handouts for parents, screening tools, treatment algorithms, medication dose recommendations, and those are based on the Health Care Authority guidelines that drive the medication reviews. Have any of you participated in the Second Opinion Network medication reviews? Oh, this is so uncommon. I'm kind of blown away. That's good. That means you're prescribing in bounds, so congratulations. So no, these are guidelines that were established to trigger a medication review with a specialist. It can be a number about, the number of medications. It can be about dosages. There are certain triggers, and it can be about dose, if you're going too high on a dose. We try and approach these calls the same way we do when you call us and look for guidance and assistance. And so hopefully they're helpful and educational when you do have to do these. The information about when to expect a phone call or have to do a review is in the PAL guide as well. And hopefully I'll be able to get my hands on some that we can hand out here to you today. But it's all online as well in PDF form, and just Google Seattle Children's PAL line and we'll come up. Yes? Good question. It's only for children right now, but soon there will be the same thing for adults through the University of Washington. So stay tuned. It will be available.